Hi, this is Richelle Marting, and on behalf of Heartland Telehealth Resource Center, this presentation is to give you an update on a recent report that was published by the Office of Inspector General, a telehealth data brief that examines the use of telehealth services during the pandemic. I'm Richelle Marting, and I've been working with Heartland Telehealth Resource Center for the last year or so and helping provide education during their webinar series on telehealth coding, billing, legislative updates, and policy implications at a federal level, at a state Medicaid level, a state legislative level, as well as commercial payer policies. The Office of Inspector General has been conducting a series of studies on the use of telehealth, particularly during the pandemic, how it compares to telehealth services prior to the pandemic, and telehealth services now. OIG is looking at both uses as well as potential program integrity risks through the use of and billing for telehealth services. So this particular data brief that this session's talking about, this publication from the OIG had the goal of understanding how telehealth was used during the pandemic and how the flexibilities on the rules surrounding telehealth, including being able to provide telehealth services to individuals at home, expanding the list of eligible distant site practitioners, eliminating the rural geographic area requirements for telehealth services, how those flexibilities affected where and how patients were receiving their healthcare services. So this study looks at what they call the prior year's data, which was from 2019 all the way through February 28th of 2020, and then beginning what they're calling kind of the pandemic period or the height of the pandemic, March 1st of 2020 going through February 28th of 2021. There were a lot of takeaways from this data brief and from the study that the OIG did, but a few key takeaways that the OIG mentioned. In their study, they found that 28 million Medicare beneficiaries used telehealth during that first year of the pandemic from March 1st of 2020 through February 28th of 2021. And that represents nearly half, nearly 2 out of 5 Medicare beneficiaries received telehealth services during that time frame. They used telehealth in that time frame 88 times more during that first year of the pandemic than in the previous year from 2019 to early 2020. Telehealth was most commonly used for office visits, and even more specifically, the use of telehealth for behavioral services in particular really stood out. Within that category, telehealth was used for 43% of the behavioral health services during that pandemic timeframe, whereas for other telehealth services in general, telehealth was used for about 13% of other healthcare services. There are a couple of interesting data points on the use of telehealth. And again, remember this study is done on Medicare fee-for-service and Medicare Advantage patients. So we have to keep that particular population in mind with this data as well. And of those users of telehealth services, more than half, 55%, only used telehealth 1 to 2 times during that period, and the remainder, 45%, used telehealth 3 or more times during that 1 year period of the height of the pandemic. And I think it's interesting that OIG calls this out because I think probably the reason for looking at that particular statistic is to try to understand if there was significant overutilization of services when telehealth became more accessible. 84% of beneficiaries received telehealth from a provider with whom that patient already had an established provider-patient relationship. I think that particular focus of the study is probably examining the flexibility that was created during the public health emergency from Medicare that typically requires a patient to have a provider-patient relationship before telehealth services are rendered. And when that flexibility was created to allow new patient visits via telehealth more readily, looking at this to say, gosh, we don't have a lot of patients going to random brand new providers to have their first telehealth service. They're going to the providers that they already have an established provider relationship with. And in going to providing or receiving, I guess, a telehealth service, the average in-person visit was around 4 months prior to the telehealth service taking place. In terms of characteristics of the individuals using and accessing telehealth services, and again, this is limited to Medicare fee-for-service and Medicare Advantage beneficiaries. But between those two groups, those who have coverage under the Medicare Advantage program were more likely to use telehealth than traditional Medicare fee-for-service. Part of that may be that prior to the pandemic, even the height of the pandemic in March 1st of 2020, Medicare Advantage already had greater flexibility to provide telehealth services than what fee-for-service Medicare had. So those beneficiaries may have already been more accustomed to using telehealth than traditional fee-for-service Medicare beneficiaries. Here you can see just a quick breakdown on the composition of the types or the categories of healthcare services that were delivered using telehealth during that key year from March 1st of 2020 to February 28th of 2021. The amount of money that Medicare paid for telehealth services during that 1 year pandemic period, that initial year of the COVID PHE, was staggering. In total, Medicare paid over $5.1 billion for telehealth services under the Medicare fee-for-service program, which was 76 times more than what it had paid for telehealth in the previous year. But that could be expected given the significant expansion of the flexibilities in the way telehealth was delivered, as well as sort of being forced or thrust into telehealth as a delivery model during that period of time. But the OIG also noted in its study that even though there was a significant increase in the use of telehealth and telehealth spending, patients were still receiving most of their care in person. So only about 12 or 13% of all services during that first year of the pandemic were rendered via telehealth. What I think was interesting as well is that the OIG found that beneficiaries still used fewer services overall, despite that tremendous growth in telehealth spending. Overall service utilization during the first year of the pandemic was less than the previous year. So this was a study from the OIG of telehealth services, and we've spent a lot of time in our webinar series talking about the difference between telehealth and virtual care services, which technically aren't telehealth the way Medicare defines telehealth or the telehealth benefit. But Medicare still looked at some of those virtual care services because they're non face-to-face or non-in-person services under this kind of global umbrella of the idea of virtual, remote, or telehealth type services. So there were 34 million virtual care services during that March 1st of 2020 to February 28th, 2021 time period at the beginning of the pandemic. These were, for example, audio-only phone call evaluation and management service visits. And if you remember during the PHE, evaluation and management codes for an audio-only phone call were payable, as well as a similar group of codes for audio-only phone calls provided for individuals who were not qualified healthcare professionals, meaning a phone call from a nurse or other professionals who cannot bill for services on their own. And then in May 2020, the payment rate for audio-only phone call visits from a qualified healthcare provider, a physician or a nurse practitioner, for example, received a bump in payment so that they were on par with what was being paid for normal office visits. And that was office visits are the primary category where telehealth services were being delivered. And the rationale was that providers were reporting those audio only phone call visits truly were taking the place of what would have been an office visit service. And as we'll talk about in just a minute, those were often used in the behavioral healthcare setting where there's a much less physical exam component to the service, and it is more counseling, discussion, and coordination of care. This virtual care category and the 34 million virtual care services during that 1 year period also include virtual check-ins. So we've had a webinar series session talking about those services, which is essentially a visit to check in between, it's initiated by the patient with a healthcare provider to determine the need to come in for an office visit. It's a pretty low payment amount, but when you spend a rather nominal amount of time talking with the patient, going over symptoms to determine if an appointment is needed. And if you determine that the patient does not need to come in within the next 7 days or the soonest available appointment, then you could bill for a virtual check-in service. E-visits, so that's like an online visit where you go through a questionnaire, a provider reviews the information and provides treatment or recommendations for certain simple acute conditions. And then, of course, remote patient monitoring, the OIG put into this virtual care bucket for purposes of this particular data report. We know remote patient monitoring focuses on the measuring of physiologic parameters, your blood pressure, your weight, your pulse oximetry. Those services increased in volume, probably for twofold reason. One, of course, the nature of the pandemic and the need to monitor more patients remotely to reduce the in-person contact between providers and patients and other members of the community, but also because of coding changes that had been taking place over the previous several years, additional flexibilities on remote patient monitoring, even outside of flexibilities from the public health emergency, that made those services a lot more desirable for providers to develop these remote patient monitoring programs. So as I mentioned, the OIG really honed in on the use of telehealth for behavioral health services, so identified by those with behavioral health diagnosis codes on the claim. And telehealth specifically for behavioral health services was a really common area for telehealth use. And the OIG's key takeaway from that is that beneficiaries really are benefiting by the increased access to mental behavioral health care services through the flexibilities that were made available to telehealth during the public health emergency. I thought it was interesting that while overall individuals who have Medicare Advantage plans tend to use telehealth more than those who have fee-for-service Medicare. Part of that may be because Medicare Advantage has had access to greater flexibilities on the delivery and payment of telehealth even prior to the public health emergency than what traditional fee-for-service has. But for behavioral health in particular, beneficiaries with Medicare fee-for-service used behavioral health services via telehealth more than beneficiaries in Medicare Advantage plans. So beneficiaries in Medicare fee-for-service were using telehealth for behavioral health services, accounting for about 16% of all of the telehealth services under Medicare fee-for-service, while only accounting for 9% of all telehealth services under Medicare Advantage. You join us for our session on the Consolidated Appropriations Act of 2022 that was just passed in March of 2022 and created or extended, I should say, certain telehealth flexibilities to take place or to remain into effect for 151 days after the public health emergency ends, whenever that occurs. You may remember that as part of that piece of legislation, the Office of Inspector General was mandated to do studies on program integrity risks of telehealth services. So as part of this particular OIG data report, there's a quote towards the end that Medicare can meet the needs of its beneficiaries. The OIG has additional evaluations and audits underway examining telehealth in Medicare to help further inform program policies and oversights. And then there's a footnote at the end that says that an OIG Medicare telehealth services during the COVID-19 pandemic program integrity risks, and it has a study number OEI 02-20-00720 is forthcoming. So that study is already underway, and we should be seeing that report, from what I understand, sometime this year. And certainly once we get our eyes on that report to see what the OIG sees as potential program integrity risks with telehealth services, we'll share that with you, because I think that really informs providers on where their greatest risks may be and where Medicare and different contractors under the Medicare program may focus their efforts if they decide to do medical review and audit documentation of telehealth services. As always, if you have questions about telehealth services, coding, billing, payment policy, you can reach out to the Heartland Telehealth Resource Center through their technical assistance email address, and we'll see what we can do to help answer those questions for you.